All right. Well, good evening, everyone, and welcome to our HSS webinar on osteoarthritis after injury. My name is Anil Nandkumar, and I'm a physical therapist with the Hospital for Special Surgery. I'm pleased to set the stage for an informative discussion on the development of OA after an injury, especially a traumatic joint injury, and discuss what the available treatment options for this condition can be. Joining us tonight, we have a wonderful panel of expert clinicians. Dr. Scott Rodeo, top HSS sports medicine orthopedic surgeon and director of the Center for Regenerative Medicine. Dr. Rodeo is finishing up in a surgery right now, so he will be joining us at some point. Next, we have Dr. James Wyss, a leading HSS physiatrist, which is the study of physical medicine and rehabilitation. He also has a specialty in sports medicine and is the physician for the Long Island Nets. And finally, Anna Ribaudo, an amazing physical therapist who is board certified as an orthopedic specialist and one of the leaders in our rehabilitation department. So jumping right in, we have our first case right here. And that will be a anterior cruciate ligament tear. So a 19-year-old athlete was diagnosed with both a grade 3 ACL tear, which is a complete rupture of that ligament, and a medial meniscal tear. The injury was treated with ACL reconstruction surgery and physical therapy. Now at the age of 40, the patient is experiencing knee pain and stiffness, which is interfering with exercise and daily activities. So going through our list of questions here, for Dr. Wyss, how common would the development of OA be in a patient with a history of an ACL reconstruction?
Yeah, so unfortunately, it's very common. And of course, the likelihood of developing osteoarthritis after ACL tear increases the number of years you are post-injury. So, some report that even less than 10 years out, we might be seeing close to 25% experiencing some signs or symptoms of it. As we get between 10 and 15 years out, some studies say it gets close to 50%. And as in this case here, we're talking about just over 20 years. And so in that time point, now it becomes even more likely. So, and I see Dr. Rodeo is just able to join us, who, if you want to fill him in on where we're at, if he's ready to join, I know this is a area of tremendous expertise of his.
Absolutely. So welcome in Dr. Scott Rodeo, in fresh off of surgery. So we're just discussing our first case here, that being a person with a history of an ACL reconstruction with a medial meniscal tear. And so they're developing OA or signs of symptoms of knee pain and stiffness at the age of 40. So the question to you would be, for surgical treatment for an ACL tear, in this case, would surgery be indicated? And also moving forward down the line, when do you know surgery is indicated for a patient with knee OA?
Well, so this is an all too common scenario. One of the unsolved problems with the ACL surgery is, in fact, the rate of post-traumatic OA over the years. Up to 50% of patients will have some changes at 15 years. So if your question is surgery initially at the time of the injury, probably makes sense. So if the knee is unstable, ACL reconstruction can reliably stabilize the knee and potentially prevent further injury, but we don't truly, or we can't prove that we can change that natural history as far as the degenerative changes. And the reason is it's complex and multifactorial. The factors that lead to these degenerative changes over time. Is your question whether she should have surgery or be whatever at this point at age 40?
I guess looking at a patient with this type of symptoms, knee pain, stiffness, interfering with their daily activities, how would you know that maybe OA is the leading factor? And when would you know that the patient may be ready for another operation, potentially a knee replacement?
Well, that's just based on careful evaluation of the patient, history, physical examination, and imaging. Patient comes in at this point, so I guess now the patient's 20 years out from ACL injury and or surgery and has symptoms. Again, very common scenario, unfortunately. And so you make the appropriate diagnosis based on imaging and physical examination. Treatment options that are very much predicated on on the findings, on the physical exam findings, importantly on the imaging findings, and then symptoms, patients' desires, things like that. Whether we typically will start with standard non-operative treatment modalities in managing degenerative joint disease. And frankly, the management principles for post-traumatic degenerative disease are similar and the same largely as for standard osteoarthritis, which are starting with activity modification, whether it's physical therapy, oral anti-inflammatories, sometimes injections, sometimes bracing, and then surgical options may be considered based on the pathology.
Great. And Anna, you and I deal with this constantly. A patient with a history of ACL now they're kind of seeing the results later on in life. When a patient comes to you, what are some things that you're looking for from your examination from a PT perspective, and what are some things that right off the bat that that they can improve upon, and exercises that you would give them?
Yeah, so strengthening is really critically important, and over time, as patients get older, as they do less activities, oftentimes an important factor in this scenario is a level of deconditioning or incomplete strength, muscle endurance and it's not just your quadriceps, but your hip muscles, your core, gluteal muscles, the whole chain. So it's critically important to really evaluate our patients in that respect. So from an orthopedic standpoint, I'm going to evaluate stability in the knee, number one. Once someone starts to have a little bit of a flexion contracture, that can be a problem. So reestablishing full motion is important. But a careful assessment in conjunction with our therapy group is critically important for identifying any deficits in strength, endurance, flexibility, proprioception, balance. All those things are really important. And those are modifiable factors. Those are factors under our control. Some things we can't change, but some things we can change. I'll tell patients the factors under their control are, number one, maintaining the ideal body weight, and number two, strengthening. So those are critically important factors and a place to start here.
And based off of what Dr. Rodeo was just speaking on, what are some exercises that you would kind of immediately go to, or what are some problem areas that you would see right off the bat?
Well, like Dr. Rodeo alluded to, I think a lot of times with these patients, part of the reason why they even had the ACL tear is usually they have some weakness above and below. So you really want to take a look at their core. You really want to take a look at their hip strength. You want to take a look at their ankle mobility. And just ask them to, I think one of the biggest problems with any musculoskeletal issue is the second the musculoskeletal issue goes away, you stop doing what helped to get it better. So it's really that education that, you do have this history, and as much as osteoarthritis is something that I would say for the most part is unavoidable, if someone at the age of 40 to have this type of discomfort is, of course, based upon the fact that they had this ACL reconstruction when they were younger. So talking about what were they doing with therapy? Are they still doing any of that now? What is their activity level? And then after you evaluate them and see where their strengths and weaknesses are, you really have to address the hip strength. You really have to address the overall leg flexibility, ankle flexibility. And like Dr. Rodeo said it before too, their balance and proprioception. The studies do show that there's a decrease in proprioception and balance on the operated leg. And sometimes after they maybe stop doing their therapy exercises, that may kind of return. So you want to make sure that they have that stability moving forward.
Great. And then lastly, Dr. Wyss, let's just say this patient is now not 40 anymore. They're about 60 now, and they're coming to see you. What are some things right off the bat that, that from your perspective of in terms of any interventions that you might go to? Let's say they're not a surgical candidate. What are some things that you're thinking of?
Well, even talking, about this patient over the years, this is a common scenario that we see, and many times I can help that patient for many years. Sometimes initially it's just hammering home a lot of the concepts that we already touched on. They lost a little extension in the knee. It's tough to get your full quadricep function back. Just making sure they're aware of these issues. And just like Anna pointed out, that they need to remain diligent with it. It can't be something that happens just in a physical therapy gym. There has to be carryover after it. And many times when people come back in and they're having symptoms again, my knee feels more stiff, my knee feels more swollen. Sometimes there's a lot of other life factors going on. They're stressed, they're busy at work, they're busy with family, and they don't have time to get to the gym. They don't have time to eat healthy, to sleep well. So those lifestyle factors are huge. And sometimes if you just kind of get people to tell you when their knee was feeling really good, what was their overall lifestyle like. You can sometimes bring them back to that. If you can't, if you do a really good job with patient education and you do a really good job with physical therapy and trying to get people to be compliant with the program, and they're still having those symptoms, we do use knee injections commonly in this group. And sometimes it's just that treatment that facilitates a little bit recovery. So they can, with treatment, they can have a little less swelling, a little less pain, and perform better with their activities and their exercises. So we used to use steroid injections, or as people would say, cortisone a lot. I would say I use them less and less, except in the case of when someone needs to feel better quickly and they really have the acute pain and swelling to warrant it. A lot of these patients do seek out treatments like hyaluronic acid injections, also known, people commonly call them gel shots, and an emerging treatment that's really been around a while and has proven to have a good duration of relief for patients with osteoarthritis or PRP injections. So these are things that commonly this individual at 40 might improve with some standard treatments and may return at a later time in life and need more than that. And that's my next line of treatment.
Great point. Great point. Yeah, definitely. This patient will probably be seen in phases of their life as things progress and things like that. Great. Moving on to our next case here about a shoulder dislocation. We have an individual aged 23 years old, dislocated their shoulder after slipping on ice. The injury was treated with a closed reduction, which is resetting the joint without incision, with an immobilization and physical therapy. Dislocation then reoccurred 2 years later. It was again treated with closed reduction. Now, at the age of 50, the patient is experiencing shoulder pain and stiffness. So with a chronic dislocator, as we call it, again, with that unstable shoulder, how common is that OA to develop after a shoulder dislocation, even a primary? Going to, let's say, with Dr. Wyss.
So I don't think we have the same data and numbers like we have that Dr. Rodeo mentioned for post ACL tear, but so it's not definitively greater than 50% at this point, but it is high. And I think it's higher with the number of episodes of instability that they had and persistent instability. I think it's high depending on the extent of bony and cartilage injury that occurs at the time. So I do think there's a lot of factors, but it is a common scenario that someone 25 years after having some episodes of dislocation, when they see me, they may be presenting with signs and symptoms of osteoarthritis that end up being confirmed on X-ray.
Very nice. And from a physical examination standpoint, Dr. Rodeo, what are some things that you might find in your practice that a patient with the imaging correlates to movement patterns of OA following a patient like this?
The important thing in this scenario is shoulder motion. So as Jim said, that we don't have as much data about post-traumatic OA in the shoulder as we do, say, in the knee, but it's out there. And to look at patients, we did a study here years ago at HSS, patients undergoing total shoulder replacement, shoulder arthroplasty for arthritis. Retrospectively asked them about history of instability, much higher incidence of instability in those patients, with an age match group. Those patients who required arthroplasty did in fact have a history of instability. So there is some relationship there. To your question, I think that a critical factor in the shoulder, as much as any joint, is motion. Patients can get away with a fair amount of degenerative joint disease in the shoulder if they maintain good motion. Conversely, if someone starts to get stiff and lose motion, then they're more likely to become symptomatic. So that's the first thing I look at. The first thing I think that should be addressed with rehab is reestablishing good motion.
Great. And Anna, when that patient comes into the clinic, what are some compensatory patterns that you may commonly see that Dr. Rodeo was talking about that decreased motion?
So it's really important. Number one, you have to know whether it's a dominant or non-dominant arm to see what they're doing with it. And then when you're thinking of someone who's 50, you got to think about their lifestyle. Like, are they sitting at a desk all day? What's their posture like? Are they actually compromising their shoulder by lack of neck motion? And really seeing what that's like. And then you need to take a look at that mobility and see, are they lacking bringing the arm up? Are they lacking bringing the arm out to the side? There are different patterns that people that can present with in regards to stiffness in the shoulder. And you just have to take a look at just their overall picture of both neck and shoulder mobility to maintain that flexibility in the upper body.
Great. And so, right off the bat, when you're starting someone on their rehab program, and Dr. Wyss, when you're educating them about, long-term management and things like that, what are some things right off the bat that you educate them on? I know in my practice, for sure, assessing their strength, but also seeing how their limbs may move with good timing and symmetry.
Right, so you want to make sure that they're able to move their shoulder without overusing their shoulder blade, right? Making sure that they can move independently from each other. There is a certain timing pattern that goes along with moving of the shoulder. So you want to just make sure that that pattern is present. I think it's also really important with these patients that shoulder strengthening does align with the mobility, but the mobility has to come first. The other important really thing is, what we talk about in regards to strength of the core for your hip, your knee, and your back, you really have to look at the strength of your upper back, the muscles in between your shoulder blades. Those are really like the core to your shoulder. So if those are weak, you're going to stress the shoulder more. So you really have to assess that strength as well.
Love that analogy, the core of the shoulder. Great. And I would also say, from a long-term management, I kind of preach posture for these types of patients. Even, sitting at a desk where we're going to have the shoulders up, rounded. As you start to focus more on the computer, your neck might reach forward and can kind of throw your posture off. So, to kind of couple that, definitely activity modification, I think for these patients is definitely part of the plan.
Yeah, and if I could just add to that, I would just say it's a common theme for me is really trying to find out more about the individual I'm taking care of and what their goals are. And so this individual may come in to see me and their shoulders functioning reasonably well during the day, but they just can't sleep at night with it. So that's one scenario. And then there's someone else who comes in and the shoulder's not functioning with recreational sports they want to do. They can't play tennis anymore, let's say. And so with that situation, I very much want to help the individual understand what their shoulder can and cannot do. They may have lost some motion, but they also may have some restrictions in motion that you can't push past. And I think people really need to understand where that ceiling is and what they can get back and what they can't push through. And then with that comes the need to maybe be able to modify those activities, like change a tennis serve a little bit. To be able to perform those activities. And I think lots of times if you take the time to explain the condition, explain where their limitations are, what they can improve, like improving strength, improving posture, but accepting some limitations, I think you can end up with a favorable rehab outcome.
Moving on to our next case here, I'm talking about a patella dislocation. A 15-year-old female dislocated her patella after falling and landing on her knee. The initial injury was treated with surgery, repairing the torn ligament, and physical therapy. Dislocation did not happen again, but at the age of 35, she is now experiencing pain in the kneecap. So, right off the bat, when a patient is going right into, let's say, a fall on the ice, dislocation of the patella, potentially they have maybe torn their patellar tendon or even their MPFL. Dr. Rodeo, if you can just speak a little bit about that surgery in terms of your timeline for a young 15-year-old active individual, when do you potentially see them returning to full function in terms of a timeline?
After an initial patellar subluxation?
Correct.
It's highly variable. This age group, risk of recurrence is fairly high. You treat there's a lot of controversy now as to whether we should stabilize knee after a first-time patellar dislocation, and the pendulum started to swing toward considering surgery after a single dislocation. Admittedly, some patients will go on and never have another problem, but the risk of recurrence is fairly high. So our challenge as surgeons is trying to identify those patients at higher risk of recurrence, because with recurrence, that does set up the risk of progressive cartilage injury. So you can make a case for stabilization after first-time dislocation in those individuals at high risk, which tends to be younger patients, ligamentously lax individuals involved in higher-level sports activities with deceleration, pivoting, things like that. So you can make a case in this. Maybe you should fix this after the first dislocation. if you're treating this non-operatively, return to activities, it can be anywhere from 4 weeks to 3 months. It's pretty variable. It's usually 6 to 8 weeks minimum. It takes time to reestablish motion in the knee, resolve the effusion. You get this reflex inhibition of the quads from the effusion and pain. So you're resolving that, then strengthening, again, back to balance, coordination, a lot of the same principles that we talked about in the ACL injured knee or the ACL rehab knee. So those same principles kind of apply here. We do know that this is a very good example of the post-traumatic arthritis that can occur after patellar instability. The factors the considerations are similar to the ACL injury knee, which are both there's biologic changes in the joint from the die is cast at the time of the injury, plus there are biomechanical alterations in that joint. So the point is, the patella is unstable, that the abnormal kinematics, the abnormal joint stability plays a role, but also at some level, and this goes for the ACL injury knee, from the initial injury, the second that happens, the transchondral injury, the cartilage injury, there's an inflammatory process in the joint that is initiated that really kind of kicks off this whole process that can lead to these post-traumatic degenerative changes over months and years. So at some level, that die is cast the minute the patient injures their knee, which also brings up, are there things we can do to intervene early in these knees?
Fantastic answer. I think, one of the big takeaways that I'd like to share with the audience is that having an injury like this can set off a concomitant set of other things that can happen within that knee, within other parts of your body too. Fantastic answer, Dr. Rodeo. And I would then go to Dr. Wyss and ask, besides knee OA, post-traumatic, knee OA here, what are some other types of, presentations that you might find in a patient like this that comes to see you? They're definitely experiencing a pain in the kneecap. What are some other presentations that might happen with this patient?
Yeah, and I guess I'll go back a little bit to kind of a counterpoint on what Dr. Rodeo was sharing. There are certainly patients with this injury who come in and it looks like they unfortunately suffered a ligament injury, like you mentioned, the MPFL, and they may have had a cartilage injury. So if I think things are potentially repairable by one of my surgical colleagues, I'm going to make that referral. Some people get lucky with the first dislocation and they avoid those extensive injuries, and sometimes you see them recover nicely. And I think in those cases, there were obviously some contributing factors, whether it's the underlying anatomy that they have, the bone structure, a lot of different factors we could get into there that I don't think we need to. But the point is if you establish that you think someone can get better with rehabilitation, then you really have to make sure they not only recover all the function, get rid of pain, swelling, restore the function of the quadricep muscle because the patellar tendon's embedded in it. I'm sorry, not the patellar tendon, but the patella itself. And then make sure they work with a really reliable physical therapist so they accomplish these goals. And we all know they're ready to return to their activities with the lowest potential risk of re-injury. Because I think in that scenario, that's the one you get concerned that the second episode may be more serious than the first.
Mm-hmm.
Very nice. And Anna, if this patient comes into your clinic, I know, just thinking about it, the first thing I will go right ahead and say is a lot of times with the pain in the kneecap there, they might have actually stiffness of that kneecap. So how are some things that you may address with stiffness of a kneecap and then also maybe a little bit too loose of a kneecap?
Right. So the kneecap is, essentially almost like a floating bone, right? So it's got to sit in its track. Right. So if it's not sitting in its track properly, either it's too stiff and it's not really centered, or it's too loose and it's not really centered. You have to assess the mobility of the kneecap in all directions, make sure it moves well, both up and down and side to side. And then just make sure the muscles that are holding it in place are doing their job. Make sure, like, commonly you'll see the lateral muscles can get really kind of like over tight and they start pulling the kneecap a little bit more to the outside. And then you have to address that. So is that tightness happening because other muscles aren't doing this job and that muscle is doing more work than it should and it's kind of pulling the kneecap out? Are the muscles on the inner part of the knee not really doing their job? Is the quadriceps a little bit inhibited? So you really have to take a look at all the muscles that are surrounding the kneecap and see what is their role and the discomfort that the kneecap is feeling. And again, similar to the first case, you really can't treat the knee without looking at the hip. If the hip is not doing its job, the knee is going to work that much harder and really can give that pain around the kneecap, that pain in the anterior knee. And you just need to take a look at that. But again, still like the first one, you have to look at their balance. You have to look at their proprioception. You have to look at their activity level. Like what are they doing? Like, are they someone who is sitting at a desk all day and then like trying to be a weekend warrior in the weekend? Is someone who's trying to run, but they don't have the hip strength to be able to stabilize that? It's really important to kind of take this person through, like, what is their day like? What is their knee? What is required of their knee throughout the day? And then take a look at the knee and then the factors above and below it.
Amazing. Yeah, I think it's so important to really look at functionally, look at the entire kinetic chain.
Mm-hmm.
How many times have we seen a patient, they are so focused on their knee, but their hips are very, very weak, or maybe not as stable when they're doing a step down. So a lot of that can tell into the knee. So great. Let's move on to our next case here. We have a recurrent ankle sprain. So a 17-year-old athlete was diagnosed with a grade 3 lateral ankle sprain, and it was a complete tear during a soccer game. The injury was treated with surgery, repairing the ligament, and physical therapy. At the age of 31, they are now reporting significant pain and ankle instability. Right with this first injury that happened with a complete tear, what are some of the things after surgery that a patient should start to do in order to regain that motion, in order to make sure that that ankle is nice and stable again? Anna, we'll start with you.
So I think with these patients, you have to be really careful with trying to regain motion right away, right? Like they already are kind of prone to instability. So you want to make sure that, their hamstrings are flexible, their hips are flexible, but their ankle should be strong, so it's not necessarily hammering away at getting their ankle to be more mobile. They definitely need the mobility to be functional, but you got to get that strength back, get their stability back, make sure they have good stability standing on one leg, excuse me, make sure they have good stability doing what they need to do functionally, making sure they have the proprioception. Are they able to balance on static ground? Are they able to balance on uneven ground? Is that present first? And then, obviously you definitely want to incorporate the flexibility so they have the functional flexibility. But I think with these patients, sometimes, there can be that want to be too aggressive with mobility when they really need stability first.
And Dr. Wyss, when this patient comes to see you now at age 31, how do you expect them to walk, like in terms of their gait pattern? What are some things that you see from your examination?
Yeah. Well, also, I'll just back up also to just a slightly different scenario. So more commonly in my practice, I'm not seeing a patient post-surgery, and many times even that grade 3 lateral ankle sprain, that recovers well without surgical treatment. So there's plenty of patients and young athletes I've taken care of over the years who have gotten back to full activity, sometimes even in a relatively surprising short period of time with good rehabilitation. And many times they're fortunate enough to escape injury. And I think we know less about exactly those who are most prone to osteoarthritis in this group. But certainly if I'm concerned that someone has more than just a sprain and their joint swollen and it's not functioning right, I often will get an MRI to see if there was concomitant cartilage injury, especially to what we call the talar dome. Then if later on, often that individual, once you have an ankle sprain one time, you're at higher risk for having it subsequent events. And that's the common scenario I'll see, where someone is coming back because they did well, but now they sprained the ankle again. They rolled it unexpectedly after thinking they were doing well. And many times it's similar to rehab scenarios we talked about earlier, that they just lost some function in that joint. They developed a little bit of stiffness. They didn't have the same balance, coordination, or strength. Maybe some weight gain, maybe different factors. And so I again go back to the point where their ankle was functioning well, and how do we get you back to that point? And so fortunately, it's not the extremely common scenario that I'm dealing with in my practice, post-traumatic osteoarthritis in this group, more the recurrent ankle sprain. And many times able to get them over to you and Anna, and they're able to rehab really nicely and get back to everything they like to do.
And if I could just add one thing to that, like any patient that I've seen later on in life who's actually had to go the route of getting like a total ankle replacement, those people are really lacking stability and balance in that ankle. So that's the thing that I think is really important for these patients, because if they have that stability, they have that proprioception, then they can utilize their musculature better to help to stabilize their ankle.
Great. And this patient is quite young. And so for post-traumatic OA, besides a total ankle replacement, is there other interventions out there, surgical interventions that you may consider, Dr. Rodeo, in terms of for this patient?
There's cartilage repair, options can be considered for focal chondral injuries. And by cartilage repair, I mean cartilage grafting, whether it's osteochondral tissue or even cell-based approaches. There's a role for these procedures for, it's in a limited group, but in a truly single focal chondral lesions. The reality is the picture you paint here is different. This is more of a degenerative ankle where we don't have great solutions surgically. I mean, you can do arthroscopic debridement, but that's going to be fairly unpredictable as far as degree and duration of relief. Ankle replacement surgery, that it's been a resurgence in ankle arthroplasty. It's a different group of patients, your older patients, and so your younger active patients, that's still not going to be a great option or a first line option by any means. It's sort of your end stage salvage procedure. So I think you're trying to simply manage symptoms in the setting, whether that's, I think, establishing better kinematics is in the rehab part, as we talked about. Maybe it's bracing, maybe it's injections, but surgical procedures, not much other than the occasional cartilage repair for a focal single chondral lesion.
So we have one more question here. And so that would be, what is the idea of regenerative medicine and how can it be treated for those OA? So if there are specific interventions, there's some that you've described already, Dr. Rodeo, if you want to just speak a little bit about the broad aspect of regenerative medicine, and then we can answer some Q&A.
I mean, you could have a whole lecture on regenerative medicine. It's the term is often used. In fact, we have a Center for Regenerative Medicine here at HSS. The reality is, although there's great potential in this area, many of the currently available treatments are not truly regenerative. They are symptom modifying. So the options that we can use that fall into this area quite simply include autologous blood products such as platelet-rich plasma, and there's a number of different formulations of these autologous blood products. Other would be cell-based approaches, and the options that we can use currently today are cells derived from bone marrow or lipoaspiration, adipose tissue, fat tissue. People use the term stem cells. They should not use that term. The cells that we can use are not stem cells by any formal cellular or molecular criteria. Now, the cells that you can derive from, like adipose, as I mentioned, fat tissue or bone marrow, there are cells that have some role as progenitor cells, but our current treatments, I tell patients, and there's good data to support this, they are symptom modifying. They can help symptoms, but very little data to suggest that they are truly structure modifying. That is, they truly regenerate tissue. Patients have this idea that these treatments are magic and are going to regenerate tissue. Currently available options, very little data to support true tissue regeneration. But as mentioned, symptom modification, there's good data to support that. And a lot of these formulations, whether it's cell therapies or autologous blood-based products, probably work via impacting the inflammatory response in the joint, the local immune cell population, inflammatory mediators, inflammatory cells. So these treatments can be very effective for treating symptoms. And to summarize, our currently available options would include PRP, platelet-rich plasma, of which there are a number of variations, and cell-based approaches, cells derived again from bone marrow or adipose tissue.
Great, thank you. We have two questions from the audience. The first one being a patient with arthritis of the big toe. The toe is mobile, but it has limitations in terms of lifting up or extension of that great toe. Their surgeon says no to surgery, but says that their ability to run and do skiing could be limited. So in terms of a patient like that with big toe arthritis, that toe is super important for us in terms of walking and just daily function. Anna, how would you manage something like that from a PT perspective?
So I'd want to find out, like, if the toe is mobile, but they're limited to lift up, like, what's limiting them? Like, where is limitation occurring? Like, where in the joint of the big toe or in the foot? You know, the foot is broken up to many different regions. So is there any limitations in the rest of the regions of the foot? Do they need to be mobilized? Do they need to be stretched? Is it a control issue? Is it a proprioception issue? Is it the way the person is walking? Are they avoiding pushing through that big toe, so they're starting to decrease the ability for that toe to move? So it really, like, requires a good gait analysis, taking a look at through the mobility of the full foot. I would say the foot's a bag of bones. So there's muscles and tendons, ligaments keeping it together. So where is the breakdown here? Why are you not able to lift up that big toe? And kind of like what we talked about today, the theme of the day, when you're looking at, like, the foot or the knee or the hip, you kind of have to take a look at the whole foot, the whole leg, and see, like, where in the kinematic chain is something lacking that for some reason that big toe is not moving.
Right. And Dr. Wyss, is there anything else that you would, like, maybe prescribe a patient like this, or maybe on your assessment that that you may have them kind of move on in terms of activity modification?
Yeah, so stiffness of the big toe, hallux rigidus, as I would say, is common. There are athletes at high level who experience that and are able to work around it. I think you keep the joint as mobile as you can, again, accepting what your limitations are. You can't push it up through a stiff point, or as we would describe, a really stiff end feel of the joint. You can't necessarily push past that. You'll make it more painful. So it's talking with people about footwear and orthotics, and are they maximizing their physical therapy related care to make sure more proximal aspects of the foot, ankle, and leg are moving and functioning properly to basically make up for that. So as opposed to fixing that issue, rehabilitating around it up the chain.
Right. And we have one more question. It's quite a specific case. I'll direct it to Dr. Rodeo. But at 68, a patient had a trimalleolar fracture of the ankle and deltoid ligament reconstruction. It was characterized as a pylon fracture due to the force of the injury and effects on bone and cartilage. What is the best way for this patient to keep post-traumatic OA minimal?
Yeah, that's tough injury. This brings up the example of an intra-articular fracture, a fracture that involves the joint surface. That is definitely a setup for later degenerative changes. We do our best surgically to reconstruct the geometry and the architecture of the joint, but it's hard to make that joint perfect, number one. Number two, even if you make that cartilage, if you say this joint looks, good as I can make it surgically, the inflammatory environment, the biologic changes that occur in that joint just at the time of injury, as I mentioned earlier, that kind of initiates this whole process here. So again, it's a lot of it. Best way time to intervene is at the time of the injury. Once you have an established process there, it's more challenging. I think you're treating symptoms quite simply. Back to the basic principles you talked about here. I think one theme you've seen here is establishing and maintaining good motion. An arthritic joint will become much more symptomatic if they start to become stiff and lose motion. So appropriate joint mobilizations, restoration, or maintenance of motion is critically important.
Great. That's a fantastic sum up. I would echo that. And from a PT perspective, your body likes to move, or it should move. And that OA, many patients will say this, they feel super stiff in the morning, but as they start getting up and get moving, they feel much better, right? And then they feel maybe the effects at the end when they're starting to wind down. So as long as you are moving and doing the right things, keeping good mechanics, good posture within everything that you do, that kind of, keeps it from a minimal perspective from that post-traumatic OA. I'd like to thank everybody here, all the panelists here for coming out and giving their expertise.